So we'll be talking about neuroblastoma this morning, and just to give you an idea that you are in a place where we see the number of cases in a year that we get to see when we are doing the clinics is equivalent to what whole of Europe sees in a year. So that's why there is, when the Europeans want to do data, they always have to all the countries need to come together, and that's why there is uniformity in their data collection, etc. But we are unfortunate or fortunate, you may look at it either ways, but we get to see those many cases sitting in one place if you just attend the JCs regularly. So for example, in 2018 we saw about 90 neuroblastoma cases who came to TMH, and we see about 2000 pediatric cancer patients, which is one of the largest in the world. No cancer hospital sees so many cancer patients in a year. Of course, majority of them are leukemias, but that's what is our workload. So once when I was abroad, one guy actually stopped reporting and said that, do you realize that yours is the single pair of eyes who gets to see maximum pediatric oncology? So that's when I realized that, okay, that I'm really blessed to work here, right? So now this talk I have divided into these topics, which are introduction, role of imaging, and role of supplementary imaging, which will help you write your theory answer as well, very well. So now coming to introduction, so it is neuroblastoma. The most common pediatric tumor is leukemia, followed by intracranial malignancies like medulloblastoma, ependymoma. So the neuroblastoma is the most common extracranial solid tumor. So amongst the solid tumor, extracranial most common is neuroblastoma, followed by Wilms tumor. Okay, so this neuroblastoma arises from primordial neural crest cells, and it is considered as a very enigmatic disease because there are some neuroblastomas like who was with me, Anurag was with me that day. It's a 4S neuroblastoma. We don't have to treat at all, and the disease will involute by itself. We have to just observe the child. We do a 3-monthly ultrasound. The disease just involutes itself completely without any treatment. Whereas on the other hand, you have neuroblastomas which need as extensive therapy as bone marrow transplant, extensive high dose chemotherapy followed by bone marrow transplant, and yet the child outcome is as poor as 30 to 40%. So a lot is depend on the biology of neuroblastoma. So that is why it is considered as an enigmatic disease. Is it slides are moving? Okay. So some neuroblastomas, no matter what, will die. However, wherever they are treated in the world, while some do not. Also, there is the presentations are very interesting in the sense that sometimes the child will present with chorioethitoid movements. What are those called? Chorioethitoid movements. It is opsomyoclonus. So it is a paraneoplastic syndrome of a neuroblastoma, which causes this chorioethitoid movements. Then sometimes the child presents with diarrhea. Why? Yeah, because of VIP secretion. So they present with diarrhea. Sometimes there are cutaneous nodules, which in color? Blue. So blueberry muffin it is called. So those are just subcutaneous. Those are child just presents with subcutaneous nodules. Sometimes child presents with proptosis because of orbital mass. So the neuroblastoma need not present as an abdominal mass. So there are varying. Sometimes the child will just present with bone pains or just lethargy. Sometimes the child will present with paraplegia or paraparesis. So the mother will say the child was not moving the legs since last 2 days. So the presentation is because of more than the mass. The presentation is because of mass effect or other hormone, other secretions that are produced by this tumor. So that makes it very interesting to look at in the clinic. So now, one second. Huh? Yeah. Sorry. Okay. So now coming to the role of imaging in 1 second. I think is it moving on its own? Was it moving? No. Okay. Okay. Let's come to the role of imaging in diagnosis. Okay. So diagnosis of neuroblastoma depends on the age and location of the tumor, right? So sometimes you know that the neural crest cells are on along the sympathetic chain extending from the skull base to the pelvis. Okay. You want to do it? क्या करना है? शेयर का बटन नहीं दिख रहा। Okay, so diagnosis is based on age and location. अभी इसको क्या हो गया? Okay, so as we know that some of my images are not coming in this. I don't know because I've copied it right now last minute. So the age slide didn't come, so I'll just speak about it, I guess. Okay, 1 second. So most of the neuroblastomas would present by the age of 5 years. Okay, about 85%. And some up to 95% would present by 9 years. Only few neuroblastomas occur in adult population. So you will have a 20-year-old with neuroblastoma very occasionally. It can happen, but most of the neuroblastomas you will get by the age of 5. And for location, so they can occur anywhere along the sympathetic chain or wherever there are sympathetic neural crest cells, right? So the common locations are cervical, in the superior cervical ganglion, in the inferior cervical ganglion where it would present with which syndrome? And the inferior cervical ganglion is what? Horner syndrome. Okay, then you can have anywhere in the posterior mediastinum along the sympathetic chain in the posterior mediastinum, similarly in the retroperitoneum. Then you will have them in the adrenal medulla, and then you have organ of Zucker-Candle, etc., where you could have them, right? So anywhere in the body they can occur, but these are the common locations where they occur. So most common location is obviously the adrenal gland, followed by extra-adrenal abdominal organs, followed by chest, and then followed by neck and pelvic regions, right? Now, when we discussed Wilms tumor that commonly neuroblastoma will show this classic ill-defined mass which is sort of merging with the adjacent nodes, encasing the vessels and not causing any thrombosis or any problems in the vessels as such. And you will have this stippled calcification. When you see this sort of stippled calcifications in retroperitoneal nodes, you should think of neuroblastoma. And sometimes the calcifications can be coarse and chunky, and you can see that the claw sign that we discussed in Wilms tumor is absent. The kidney is pushed inferiorly, and that's how neuroblastomas look. So they are very heterogeneous tumors with solid cystic areas are uncommon, but solid areas which are heterogeneously enhancing because they can have differentiation. Some areas would be purely ganglioneuroma, some would be neuroblastoma as well. So it is variable in its appearance. With if you see the stippled calcification, this side one is more characteristic than you will think. And then when I talk about patterns of split, this is how the nodes will be. So the primary will be merging with the nodes, encasing the vessels without causing any thrombosis. And there can be contiguous spreads. For example, an adrenal neuroblastoma can extend into the posterior paramediastinal region if it's a thoraco-abdominal neuroblastoma. And when it commonly at multiple sites, it can extend into the intraspinal foramina as well. Like it is not necessary, but you will see it commonly. The erosion of the bones is not that common. If there can be secondary erosions or changes, more than erosion, it is often changes. The ribs can get expanded. They look this plastic sort of things. Erosions are not common. And you will have these conglomerate masses together. So when you see this pattern, you are quite certain that it's neuroblastoma. Again, in this node, I don't know how clearly you can see, but there is stippled calcification. So sometimes the primary is not very obvious, and you just see lots of nodes in a small child, which are the stippled calcifications. The first thing you should think about is neuroblastoma. Otherwise, the common differential for adenopathy is going to be lymphoma. But lymphoma will never show this sort of calcifications, right? Then sometimes there are classic presentations. This is called as a hair-on end appearance, which is also seen in anything that infiltrates the marrow, like thalassemia. But in neuroblastoma, mets can also cause. Recently, there was a case here. I think it is CS157, if I'm not mistaken, which had this classic appearance. And then these are classic bilateral symmetrical orbital wall metastasis. So sometimes when the child presents with proptosis, this is the first scan that you would do. But when you see something like this symmetric, you should think of neuroblastoma. Okay. So that is how you help in diagnosing. Now, after having diagnosed it, the role of imaging also comes in staging and treatment planning. Okay. So now, in 2009, there was an update in the neuroblastoma staging, and this is what the world follows now. This is called as International Neuroblastoma Risk Grouping INRG staging system, INRGSS staging system, in which there are a lot of things, and if you notice, a lot of things is based on the biology, the histology category, the rate of differentiation, ethnic amplification, and all that. But there is an important column here on the side, which is what imaging does. So this was an upgrade. Till that time, there was no role of imaging or local disease extent in staging of neuroblastoma. The staging was always a post-surgical staging, and I will come to that later on. But with this staging, now we have to stage neuroblastoma upfront based on imaging, and we give it into 4 stages, which we will discuss shortly. And a lot of it is based on biology. So neuroblastomas, and now you can imagine how complex it is, because after doing a staging, you do biopsy and then you do some enmic amplification, and then in certain cases you need to do some chromosomal studies as well. You look at ploidy, and then you divide neuroblastoma into various risk groups, and the treatment varies. So very low risk you do not treat, and high risk you need to do bone marrow transplant. So you have very low risk, intermediate risk, high risk, and neuroblastomas at the end of all this staging system. So this is what is routinely done for all patients who come to Tata as well. So coming to where the role of INRG is what we are going to discuss now, and this I have already sort of made a slide of what I already spoke. So this all is important in staging of neuroblastoma. So before INRG, what we used to do, there was something called as an International Neuroblastoma Staging System. So this staging system was a surgico-pathological staging system. So it was based on how much the surgeon could excise and what the pathologist found on pathology. So we don't have to remember this staging system in great details, but there are certain points that you can remember, and I will come to that again when I differentiate the 2 staging systems. One important thing is being how completely could the surgeon excise the tumor. So if the surgeon could do a gross stage total resection, it became a lower stage disease. But if the surgeon was not able to do it, or the tumor was crossing midline, okay, then it became a higher stage disease. Now you can imagine when it is based like this, it depends on the expertise that is available at an institution in terms of the surgeon and an infrastructure as well. So if the surgeon is in a good hospital, the same surgeon in a good hospital, if vascular resections can be done easily, if he by chance causes injury, so he will be more bold in resecting neuroblastoma. So the same and you by now the images that you have seen, very rarely is neuroblastoma circumscribed. It is usually associated with adenopathy. So a lot of this staging system was based on the infrastructure or the expertise available at a given institute. So the same disease would be, say, stage 1 at my hospital, and if somebody is operating in periphery, will not do not do an heroic surgery, will call it stage 3 disease. So this was the problem with this sort of a staging system, and that's why they decided that we need to move to a newer staging system. So I already covered this, and when you're doing this, obviously, then all stage 1 are not similar to all stage 3s. So again, your comparison of trials becomes difficult. And sometimes patients are not even operated. So how do you stage those neuroblastomas? And that's why they published this INRGSS, which is the International Neuroblastoma Risk Group Staging System, and which is now utilized in clinical practice. Now, the difference between INSS and INRGSS is that it became more objective because it was image-based. So imaging can be centralized, it can be reviewed. It became more reproducible, and then it became uniformly applicable across the world. So somebody sitting in South Africa and somebody sitting in America will follow the same staging system, and it helped in comparing risk-based clinical trials. So now this staging is done prior to the surgery, unlike how it was done. Now this staging system is very simple in terms of that you have to decide whether the disease is first localized or metastatic. If the disease is localized, then you have to decide whether there are any image-defined risk factors, and we'll come to the image-defined risk factors. So if the disease is localized and there are no image-defined risk factors in that patient, and it is in one body compartment, so it is an abdominal neuroblastoma, then it is considered as an L1 disease. And if there are any IDRFs, it is always considered as an L2 disease. So it's very unusual to find an L1 neuroblastoma unless it was detected because patient went for abdominal pain and then they picked up something. It's very uncommon. Most of the neuroblastomas would be L2. And if there are distant metastatic disease like to the bone marrow, liver, or nodes, distant nodes, it is called a stage M neuroblastoma. But there are certain sites of metastasis which are special in neuroblastoma setting, and those are metastasis in an infant. When we talk about infant in neuroblastoma, the age is considered as an 18 months period. So in an infant who is less than 18 months, or to be precise, they say some 547 days. A child who is presented under the age of 547 and has metastases which are confined only to the liver, or only to the skin, or only to less than 10% of the bone marrow. This is considered as a special stage of, first it was called as 4S, now it is called as MS. So this neuroblastoma has a very good outcome as compared to the other metastatic neuroblastomas. So this is considered as a 4S disease. Now it is very important to remember that this criteria of bone marrow infiltration needs to be followed. It should be less than 10% of the marrow which is involved on a given smear. Okay, and that is a little tricky portion. So commonly, what we do in practice is that if you see uptake on PET-CT and the bone marrow is come positive, then it is considered as stage M. But in MS, you may not see the bone marrow will be involved in pathology. You may not see any uptake on PET scan or MIBG. Only MIBG uptake is still considered as 4S, but I'm talking about PET-CT in specific. And I'll tell you why we do PET-CTs and not so much of MIBG as well. So these points are very clear that loco-regional meaning two body compartments. So abdominal, pelvic or thoraco-abdominal or cervico-thoracic automatically will become L2 disease, right? Now these are the IDRFs. Now there are 20 IDRFs, but we don't have to memorize them, luckily, because if you use your logic to know what is the vital structure in the given area of the body and how is it involved. So how is it involved? They have provided us with definitions. Then when do you call it contact? When do you call it encasement? And you will see all of them. Okay, we'll come to that IDRFs a little later. So now what are the other differences between INSS and INRGSS? One is that this was surgical based, this is imaging based. Now your local tumor was divided into 3 stages, now we divided it into 2 stages. You have either L1 or L2 and you had your stage 1, 2, 3. Then lymph node status, there was importance given to whether it is ipsilateral node or contralateral. So if there was a contralateral node involved, it was considered as stage 3. Here there is no importance to the nodal station. Wherever the node is, it will become L2 disease if it is non-metastatic. And importance was also given to midline in this. So across the midline was considered stage 3. There is no importance to midline. And the age limit for 4S was earlier exactly 1 year. Now it has become 18 months. Because what is believed is that this neuroblastoma has actually been there for a long time before the child actually presents with it. So outcome is very good even up to 18 months of age. So now, what are the imaging requirements for documentation of this local disease? So we have to say whether the image-defined risk factors are present or absent. And if there's disseminated disease, like if the disease at multiple sites, then we record the IDRFs only for the primary site. So if it's an adrenal neuroblastoma, we talk about abdominal primaries. We will not say for the supraclavicular node whether IJV is involved or not. You may say in your report, but that is not taken into account. If it is multifocal disease, like sometimes you have a non-contiguous thoracic neuroblastoma and an abdominal neuroblastoma. Then one which is more aggressive or more extensive, that is the one which will record. And ascites or effusion is not very common in neuroblastoma and it is unlikely to be metastatic. So if that is the only thing which is likely to upgrade the stage, then you have to prove it with cytology that it's metastasis. Often it will be reactive. First of all, I have hardly seen effusion or ascites in neuroblastoma. And if it is there, then you need to prove it to be called metastatic. Otherwise, it is considered as non-metastatic and just mentioned. Okay. So now what modality would you prefer to do, CT or MR? So obviously most of the times we do CT because it is more easily available to us for a child and we can do a CT biopsy in the same setting. So you give GA, these children are less than 5 years, you sedate them, you want to also plan the biopsy in the same setting and it's more widely available in the country. But there are certain advantages of MRI, radiation and all is being secondary, but more important is intraspinal disease extension and detection of narrow metastasis. So you can, this chart you can make in your exam what to do. More often we end up doing CT, but abroad most of them will undergo MRI even for abdominal neuroblastomas. Okay, that is because it's not very easily available to us. Now the terminology, I said it's not only that IDRF is present, you have to use specific words. So now for vessel, you have terminologic separation, contact and encasement, and this actually is practical for all tumors across the body. So like for example, if I have to say whether this esophagus is involved or not, I will say there is a clear fat plane right here, or for example, for that matter, if this carotid artery is involved or not, there is no contact only. So this is clear separation. Whereas if you look at this one, there is less than 180-degree loss of fat plane between the two vessels, the subclavian and the mass. So this is considered as contact. And when it is more than 180-degree encasement, it is considered as an encasement of the vessel. Sorry, it is 270. it is 270, not 180. Except for renal arteries, it is 180. Except for renal arteries, it is 180 degree. Okay, so it has to be more than 270 degree surrounded by the tumor with loss of fat plate to call it encasement. And if it is separation or contact, you would say this is L1 disease based on that particular structure. And if it is encased, it becomes L2 disease. This is mainly for the arteries. For airway, you use the word like compression. So like this trachea is become vertically oriented. It is narrowed. So this is L2 disease. For airway, you use the word compression. For adjacent organs, you can use the word like infiltration or invasion when it is present. And any loco-regional disease or any multifocal disease is always considered as an L2 disease. So these are the things which will make the neuroblastoma L2. Okay. So now coming into specific IDRFs, like we start from the top. So for cervical region, the common site of origin is superior sympathetic ganglia. And where is this ganglia located? Which space in the head neck region? Which space? Not vertebral. Carotid space. Where in the carotid space? Anterior, posterior, medial, posteriorly. Right. So you can see here the carotid artery is completely encased because this tumor is coming from the carotid space. This is the parapharyngeal space. So when the tumor is coming from the carotid space, the vessels would be displaced anteriorly if it is not encased in them, because the sympathetic chain is lying posteromedial to the carotid chain. The vagus nerve lies between the carotid and the IJV, and this one lies completely medially. So if both are pushed in children, that is not a common differential schwannoma versus neuroblastoma, but you can use in smaller tumors, you can use these points as well. So superior sympathetic chain lies posteriorly. So if it is coming from the superior cervical ganglia, it would commonly encase the carotid or vertebral arteries or internal jugular vein, right? So, or it would infiltrate the skull base, or it would compress the trachea. So these are the three things that will make it an L2 disease. So airway, intracranial extension, and encasement of the major vessels. These are the major vessels, right? Carotid, IJV, and vertebral. These are the major vessels that you're worried about. So if anything is present, you call it L2. For cervico-thoracic, it comes from the stellate ganglia, which we know is located above the subclavian artery at the origin of the vertebral, right? So in this region, what is the important structure? The brachial plexus, the carotid artery, the vertebral artery, the IJV, the subclavian artery. So any of these are involved, it becomes an L2 disease. Okay, so it's as simple as that. So whatever is involved, like brachial plexus, carotid, vertebral, or trachea, you call it L2 disease. Then when we move to the thorax, similarly, thorax, what are the important vessels? Aorta, aorta, vena cava, heart, etc. If that is involved, that becomes an L2 disease. But there is one important factor that I keep talking about, that you have to talk about tumor infiltration of the costovertebral junction between D9 to D12. This is important because of the artery of Adam Cavex, which comes from the aorta and supplies the radical artery to the spinal cord. So if the tumor is here, while excising this tumor, you could accidentally cause injury to the spinal cord, and that's why this is one additional IDRF that you can remember for thoracic neuroblastoma. Otherwise, it is the major vessels and etc. and pleura, pericardium, and diaphragm. Okay. For abdominal neuroblastoma, again, apart from the aorta and IVC, you will have porta hepatis infiltration, and sometimes they call it something called as the hepatoduodenal ligament. So porta hepatis is the upper end of the same thing, but hepatoduodenal ligament is the from where the portal vein and the CBD travel. That area is called as hepatoduodenal ligament when you talk about neuroblastoma. So if you see hepatoduodenal ligament or porta hepatis infiltration, it is an L2 disease. Obviously, infiltration of the major vessels at the root is considered as the L2 disease. And if the superior mesenteric vessels are involved in the mesentery, that is also considered as an L2 disease. So often it is like that. It is often L2 disease. Now I told that renal artery 180 degree is also considered as an L2 disease, or tumor which is encasing aorta, IVC, and direct infiltration of organs like kidney, liver, pancreas. Not very commonly seen. Kidney is seen commonly, but other organ infiltration is not seen commonly. If that is present, you will consider it as an L2 disease. For pelvic neuroblastoma, again from important vessels, you have to remember, you draw a line in the region of greater sciatic foramen from the pelvis to the sacrum. Okay, you draw this line sort of, and if it crosses the greater sciatic foramen, then it is considered as an L2 disease. So this is an additional IDRF that you have to remember apart from vessels, right? and here it would come from the hypogastric sympathetic plexus or precentral sympathetic plexus. So you can get pelvic neuroblastomas, correct? So don't try to mug up those 20 things, you just remember vital and then you can remember. Now important separate IDRF which can occur at any level is intraspinal extension. Now commonly you will see neuroblastoma going into neural foramina, but if it is less than 1/3, and especially where the canal is wide in children, if it is less than 1/3, or you can see the cord is only pushed, it is not compressed, and there is a perimedullary space seen, which you will appreciate better on MRI. You will see a CSF space still. It is considered as an L1 disease. It is not considered as an L2 disease. So more than 1/3 of the spinal canal should be involved like this, or that CSF space has to be obliterated. This may be hard to pick up on CT, but usually, this is never the only IDRF which is present. The patient would have more than one IDRF. It's never critical to decide. Even if the surgeon sees this sort of a disease, he is not going to operate upfront, because this kind of tumor will often have other IDRFs. So this is important to remember, that it has to be more than 1/3 of the spinal canal involvement. Now, when they did analysis, it's very logical that patients who had more IDRFs had a little poorer outcome as the patients who did not have IDRFs. So they said that IDRFs were present in 21% of patients with stage 1, 45% with stage 2, and 94% of patients with stage 3 disease, which is very logical. And patients with INRGSS stage L2 had significantly lower 5 years event-free survival than disease with L1, because obviously you can do better surgery and better treatment. So this is very logical that they concluded. Now, one thing you have to remember, that even when you give chemo, so now traditionally what happens when the patient comes to clinic, we do the staging, and if it is L1 disease and if the surgeon feels this is suitable for upfront surgery, we go ahead for surgery. Sometimes we may still not, that is for different reasons, I will not talk about it right now. But if it is L2, definitely the surgeon doesn't prefer to go ahead for surgery. Now, when you give chemotherapy for neuroblastoma, again like Wilms tumor, it doesn't disappear. Or breast cancer, it doesn't disappear. It just continues to stay there, because the tumor becomes more mature. It may decrease in size, but it may develop more benign sort of a differentiation. Like it may become more like ganglioneuroma, or differentiation starts happening. So it may start showing more calcification, etc. So your IDRS may reduce in number, but may continue to be present. So that doesn't mean that the tumor is unresectable. The presence of IDRF should not be considered as an unresectable disease, is what we are trying to say here. So still there are parts in the world even when there are IDRFs, they may still decide to go ahead with an upfront surgery. So it is not considered that if IDRF is present, it is unresectable. It is only for the purpose of staging. So to decide between IDRF whether it was L1 disease or whether it was L2 disease. That is the purpose of IDRF. And having said so, because we do INRGSS pre-op, when the patient undergoes surgery, the surgeon also records the INSS, the original staging, which is there. That is also recorded by the surgeon and kept. It may help in future research or whatever it is. So basically, when this came in 2009, it was brought up under a trial sort of a setting. It was not brought up, but practically everybody liked it so much that it kind of replaced the routine practice. But that was not their aim. So we record both. Okay. So you should not consider that this is in-op disease. Now there are certain issues when you look at IDRF. Now when you look at outcomes and all that things, but this is more for pediatricians, so I don't know whether I should do it. So like for example, we don't know what is the impact of contralateral adenopathy, but later on there were some papers which said that only metastatic disease to nodes, that is like a abdominal neuroblastoma with a supraclavicular node, should be considered as a 4N, and maybe in future this might come up, the 4N stage or something like that. They are talking about it in the literature, but it is not yet added to INRGSS. So we do not know these issues will come with IDRs. Now this is all for local staging. Now imaging also plays a role. This is fine, right? Local staging. We also plays a role in evaluation of metastatic disease. And where do the mets of neuroblastoma commonly occur? Is bone marrow, nodes, and the viscera, like liver. We talked about. Now, by the paper of INRGSS, the preferred modality for evaluation of metastatic disease is MIBG. We do not do any CT scan, chest, abdomen, pelvis for metastatic disease evaluation, because we know that CT is suboptimal for evaluation of marrow as such. So MIBG is the investigation of choice for metastatic workup, and they say it is mandatory and it should ideally be done prior to surgery, because sometimes there are neuroblastomas which are so undifferentiated that they do not concentrate MIBG. That would be less than 10% neuroblastomas. But in that case, obviously, if the primary is not concentrating MIBG, then it's unlikely that the metastasis of that primary, so it may be a false negative MIBG scan. So they want to know before they operate whether this was MIBG concentrating neuroblastoma or not. So that's why it should preferably be done prior to surgery. Now, if there are unequivocal metastasis, you can see proper narrow lesions, proper bony lesions, it is considered as an M stage. But sometimes you are not sure on MIBG, whether it is metastatic or not. Then for that localized part, say suppose there is only focal uptake in one vertebra, then you do an MRI for confirmation whether it is really metastatic or non-metastatic. So if it is unequivocal, it is considered as stage M. If it is equivocal, you supplement it with X-ray, MRI, CT. Commonly it is MRI, which we would do. And earlier times they used to do bone scans, but now we don't do it unless we don't know whether the tumor was MIBG avid or not. And if there's again uptake on bone scan, you need to confirm if you're not sure whether it is metastatic or not. So the role of bone scan has gone. There used to be a lot of discussion on cortical versus marrow metastasis in routine neuroblastoma clinics, but that has become sort of irrelevant. They used to say that MIBG picks up narrow metastasis and bone scan picks up cortical metastasis. I've never got that funda, but now there's no need of doing bone scan when you're doing MIBG. And what is MIBG? It is meta-iodobenzyl guanidine, which is basically a norepinephrine taken up by norepinephrine transporter. So it is like an analog of norepinephrine, right? So now tumors which express this norepinephrine transporter will pick up MIBG, right? So commonly it will be neuroblastomas, but some ganglioneuromas or ganglioneuroblastoma can also pick up MIBG. Then there are some other tumors like the neuroendocrine tumors, NETs, also can pick up MIBG. So any cell which produces any transporter can pick up MIBG. So MIBG does not get metabolized in the body in terms of liver or anything. It is just taken up and excreted by the kidney. Okay, that is what you have to remember. And normal physiologic uptake is seen in the salivary glands because they have a lot of MIBG in the liver, in the heart, and because it is excreted in the bladder, you will see it in the bladder. It's not taken up in the bladder because it's excreted via kidney, you end up seeing it in the bladder. So this is like a normal MIBG scan. Now you will notice that this picture is not looking very much like a textbook MIBG scan because I'll come to that later on because this is a 131 MIBG, and I'll tell you that because it's important for you to write in your exam. And now, for example, this is a child who has this localized sort of neuroblastoma here, and the liver is grossly enlarged. You can see this is one of those 4S neuroblastomas. You can see liver is hugely enlarged, and you can see localized uptake in the tumor and even some mild uptake in the liver. So, and there is no uptake anywhere else. Then you are certain this is a 4S neuroblastoma or MS neuroblastoma, right? Now, like I said, this image is not very great. When you open any textbook, you will see better images, and that is because we are in India. What is available to us is iodine 131 MIBG. MIBG is tagged to an iodine molecule which will emit gamma rays, right? What is actually required by INRGSS is iodine 123, but to produce iodine 123, you need a special cyclotron, and the half-life of iodine 123 is also lesser than 131. While this they can produce over the counter, like they have a smaller production unit and they can make it on their own. So this is more expensive and not available in India, and that's why our images do not look that great as compared to the textbook pictures. And that is also because the half-life of iodine, I'm telling you because you can write it in your exam, and I'm not bluffing on this. Iodine 123, the half-life is 13 hours, only 13 hours. So in 13 hours, it will become half of what it was earlier, given dose. While iodine 131 stays in the body for over 8 days. So it is going to keep on emitting gamma radiation for longer. Moreover, iodine 123 produces only gamma rays, while 131 produces gamma as well as high energy beta, and that's why whenever we are treating neuroblastoma with MIBG, we are using iodine 131 MIBG and not 123 because it stays in the system longer and it causes sort of ablation within the body. So because of this, obviously we cannot give the dose that we need to give to get good quality images of 131 because we know the child will keep on getting excessive radiation. So the radiation of 123 is 5% of what is of 131, and that's why our MIBG images are not very good. what we get, and that's why 123 is better, because we can give higher dose. We know that only 5% is going to get excreted out sooner, and it produces more crisp images. Okay, and it leaves larger doses, better images. But we are doing with MIBG, and because of this, what we are commonly doing in our institute is PET-CT. We are feeling that PET-CT is more better than MIBG in detection of metastasis, because the resolution of the scanner is much better. So we were doing it because we are not happy with this, and now we are going to publish that data as well. It was presented, and wherever there is no 123 MIBG, we can do a PET scan instead of that also. Now, whenever you're doing this is a gamma imager, so you can use PET to improve your detection characteristics. That is like for any nuclear medicine scan. And there is something called as MIBG scoring. I'll not get into details of this because it's already 9:30, but you have to know that there is a semi-quantitative method which sort of tells you how much was the disease load when they began and how much it is later on. So there are many scoring systems available. The one which is commonly used is called as a Curie scoring system, and it divides the body into 9 segments. Okay, and if there is 9 segments for involvement of marrow. Okay, so if skull is involved, if limbs are involved, etc., etc. So we'll no need of getting into detail. And if there's a soft tissue involvement, it is called as 10th segment. And how many segments are involved and how severely they are involved, there is a scoring system which is done by nuclear medicine people. So you can have maximum score of 30, because if all 10 segments are involved and it is lot of involvement, diffuse involvement, it gets a score of 30. Okay, and then they do it at metastasis, and they do it after therapy to see how much is the response. So you can just talk about this scoring system. Now, what are the disadvantages of MIBG? That not all neuroblastomas are MIBG avid. So now imagine if the neuroblastoma becomes extremely undifferentiated. It is no longer looking like a neuroblastoma. It will not express any transporter. So it will not pick up neuroblastoma. Okay, and those neuroblastomas actually will be better picked up on FDG PET. Okay, the more undifferentiated the neuroblastoma is, higher is the FDG uptake. So not all are MIBG avid, and that number can range from 70 to 90%. And in 10% of cases, even when the primary shows uptake, the metastasis may not show uptake. And again, you cannot use to distinguish whether it's a ganglioneuroma or a ganglioneuroblastoma or a neuroblastoma. You cannot use MIBG, because all 3 can show MIBG uptake, though it's most commonly seen in neuroblastoma. Okay. Then it has technical limitations which we decided, and there is a lot of preparation. I have not spoken about that. Whenever you're doing the MIBG scan, you have to suppress the thyroid. So patient has to take potassium iodide, otherwise it will ablate the normal thyroid. So there is a lot of preparation which goes on, and the scan is done over 3 days. MIBG scan is done over. There is a whole article on MIBG neuroblastoma. It needs to be done over 3 days. The child comes to the hospital for 3 days, and then you finally give the score. So it is very technically challenging to do an MIBG scan in a small child. And so we often end up doing PET CTs, and now you can see this was our own patient with MIBG imager, and see the PET scan. This narrow uptake is seen here, which is not even appreciated here. So that's why we end up doing a lot of PET CTs. Of course, when you give therapy, MIBG uptake goes away, but if it remains persistent, it is used as a marker for poorer outcomes. So say suppose if you want to plan a bone marrow transplant, if that MIBG continues to show uptake, we do not do it, because that such an aggressive treatment may not give the results that we desire. Okay. So bone scan, I already spoke when to use it, but it is not a preferred modality. And you can have false positive in children where there are growth plates or some incidental fractures, that you have to remember. So we do PET scan, and we know what PET scan is, right? So you can see again comparative cases how much better the PET scan is looking, because we are doing iodine 131 MIBG, right? So PET CT is especially used in non-MIBG avid neuroblastomas. It's more easily available. It is a shorter scanning time, like 1.5 hours में हो जाता है. There are many studies which have compared PET versus MIBG, and all these studies will show that PET is equivalent to MIBG or something like that. But that is because they are using 123 MIBG, don't forget that. In certain cases, PET is superior, for example, non-concentrating neuroblastomas, etc. Right? Now, again, I'll not get into these details, but I already cover this, right? That detection of primary will be better because PET is combined with a CT, so you can see the stage, the primary much better on a PET scan. And extra, whatever small study we have done, we found that picking up of liver or nodal disease is much better on PET CT because actually you have a CT to correlate with. That's why we find it easier to do it, and your scanning time is shorter. Right. Now coming to response evaluation, we'll not get into great details, but neuroblastoma response is not, again we are not using RECIST. So you have 6 outcomes after chemotherapy. You have a complete response, very good partial response, mixed response, no response in progressive disease. So we'll again, this whatever you will have to do CT or MR for local staging and MIBG for if the patient has metastatic disease, and then you decide how much is the response and give it. So you just remember that there is a different response evaluation criteria that is there for neuroblastoma. And this is just a pre and post treatment scan to show you this MIBG constituting neuroblastoma has completely responded on post treatment. So this is like a CR. For follow-up imaging, yes, very often you can imagine how neuroblastomas are like invading the normal tissue. So it is not possible to receive them, have an R0 resection like in the rest of the body. So the word we use is GTR, where we can remove more than 95% of the tumors. And very often when these patients come for follow-up, there will be some residual disease in them. So we use follow-up imaging to see if it has remained stable or it is involuting or it is progressing. So it is used, imaging is also used for follow-up. And supplementary imaging, just one last word on whole body MRI. Everywhere it started coming in at some point of time. But whatever study we also did, we found that MRI, because whole body MRI at that point of time was not so advanced. We just basically used coronal stir and T1 weighted images. We found that PET-CT was superior in detecting nodal and liver metastasis as compared to one whole body MRI because they can be really, really small, right? So there are again studies which have compared the two. But it's not a standard of care. You can just write it to complete your answer. And there is something called as a somatin receptor scintigraphy, which everybody is now aware of, which is again used like DOTA scan that commonly is done outside Tata, but it is less sensitive than MIBG for neuroblastoma. But there are studies which say that MIBG concentrating neuroblastomas and somatostatin recepting neuroblastomas, there is a difference in their differentiation. And if a neuroblastoma concentrates the somatostatin, you can use lutetium for treating that neuroblastoma. Like MIBG 131 can be used to treat and concentrating neuroblastoma. Similarly, you can use this. So this is again a lot of research is going on, and that this is like for advanced grade. I'll not get into this. And then there are right. So to conclude, imaging plays a role in diagnosis, staging, response evaluation, and follow-up. Right? Everywhere imaging plays a role, and it is very specific for neuroblastoma. That's why we need to know neuroblastoma in details if we are going to practice it. You can use RECIST and all those things. Remember that it's not really going to decrease in size. You should not call it not responded and all these things. You know. So recently there was a patient who was in the this thing, and it was the faculty who did the ultrasound, and it was an MBBS student, and the person was told that you have a residual disease and blah blah blah. And because we don't know, the other consultants also don't know that neuroblastoma is often left behind. If there's intraspinal disease, we just leave it behind. We don't bother to resect it, and it created a lot of havoc. So don't counsel the patient if you don't know anything about that patient, or at least see the old scan. So actually, it was just residual disease which was always left behind. Okay. So it's managed a little differently from other tumors in the body. So you have to know it before you counsel patients. Yeah. Okay.